Hello, good afternoon. Welcome to all of you. On August 19th, we welcome you to our eco-series um, comprehensive nutritional intervention for the management of chronic diseases in primary care. My name is Nicole Marrero, and I will be your moderator today. As always, please use our chat to introduce yourself. All the time, it is going to be available. So you can share with us where are you from, what is your profession, your municipality or your clinic, and we can uh, exchange during all the presentation. I remind you that we have simultaneous interpretation services, and you just need to go to menu. There is an icon where it says interpretation. Please click where it says more, and there you can select the language that you prefer. So in Spanish, you will be staying in this room with us, and in English, you will be listening to the interpreters. And now we will continue with the agenda for today. We will have the welcome, the general rules for the session, the interactive telementary project for health professionals, the methodology, the clinical case study. We will have today a clinical psychologist, Adriana Oden, and a nutritionist, Keyla Ortiz. And then we will have a clinical case together with the recommendations that we will be discussing as a group, an evaluation, and at the end, the announcements and closing. As a reminder, this series offer credits on continuous education. They are totally free. We need you to register, please, with your name, profession, and what will be the next sessions. And this is for physicians, nurses, and licensed nutritionists and dietitians. So again, you just need to register, and the link is on the chat. And you can participate in the session. So you are all welcome to participate in this session today. So we invite you to please, as much as possible, turn on your camera because we want to meet you. Please participate, engage, and share your experiences since this is an educational session where, where we all learn and we all teach. And we are going to be paying attention to the chat for your comments. This eco methodology has four principles: applying technology to make the most of the available resources, to share the best practices to reduce disparities, a clinical case study to facilitate the complexity of the cases, and to have a database to monitor results. So we all learn and we all teach. And here you can use the QR code on the screen for the pre-test for this session. We are going to have 8 questions in the pre-test. So we are going to give you just a moment to fill out the questions. Remember that you can see the link on the chat, or you can see the QR code on the screen, or you can go to menu and check on polls if you are not seeing the pre-test on your screen already. Great. I love seeing the faces around here. Hello, Ms. Estrella, Abigail Lasalle. I know that we met an in-person session. Hello. I am so happy that you're joining us today. So to make the most of your valuable time and your resources, we are going to start with Adriana Oden. She's a clinical psychologist. So welcome, Adriana. Please go ahead. Hello, everyone, and welcome to our session number 5, Mental Health and Nutrition. This is a comprehensive approach in primary care. My name is Dr. Adriana Oden, clinical psychologist, and I will be exchanging with you knowledge and impressions today. So let's go to the next slide, please. Here we have the objectives for this session. After this session, we hope that the participants will be able to recognize the relationship between nutrition, mental health, and the environment of a patient, identify the eating patterns influenced by emotions and social factors, and to apply brief tools in mental health to strengthen the adherence to the treatment of chronic conditions. My purpose is to offer you practical tools that you could integrate in primary care to complement the nutritional management and to promote the adherence to the treatment of chronic diseases. And why do we need to talk about mental health when we're talking about nutrition? Well, I am very excited to talk to you about a topic that we can all relate to it since nutrition is one of the primary needs of human beings. However, eating is not only a biological act, it is also a behavior that is influenced by our thoughts, our emotions, our relationships, and our context. And that's why we can see on the chart how the patient is the center of all these interactions between mental health, the family setting, chronic conditions that they live with. So if we want to have sustainable changes, it is important to understand how these factors influence among them with each other. And what determines the eating behavior? Well, the eating behavior, it refers to those behaviors and those psychological processes that influence in terms of when, what, how, and why a person is eating. So the eating behavior does not refer only to that nutritional knowledge or the willpower of a person. As we already saw, it is a psychosocial process. That's why when a patient is not following the nutritional recommendations, we must ask what factors are influencing this behavior. And we can explain this very well with the analogy of an iceberg. What we see, that the tip of the iceberg, what is above the water, is the emotional behavior. The patient is it overeating? Are they not eating enough? That's what we see. But underneath are all these psychological, family, social, biological factors which influence this conduct or this behavior. In terms of psychological factors, we can see where we have uncomfortable emotions like stress, anxiety, depression. Many times when there is an emotional upset, food becomes a strategy to manage the emotions. And also, we have automatic thoughts. For example, if yesterday I had some pizza, having a hamburger today, it doesn't matter since I already ruined the diet. And those thoughts reinforce that problematic eating behavior. In terms of family factors, we know that eating behavior is learned in the first years of our life, that children learn through modeling, and that we integrate all these habits and all these beliefs. In terms of habits, many times we use the food as a reward or as a punishment. For example, you didn't pick up or tidy up your room, then you are going to eat that broccoli. And I don't know if you remember when in Puerto Rico, when we had a Checkers, a fast food chain, in my family, they would use the fries and the chocolate milkshake as a reward. If you had good grades, we would go to Checkers. If you got out early from school, we would go to Checkers. So I would love to listen uh, to how in your family setting food was used as a reward or as a punishment. I would love to listen or to read your comments. Also, we have the social factors in terms of culture. We know that much of the socialization in this country goes around food and drinking. In terms of economy, I always remember a case of a lady with heart issues. She needed a low sodium diet, and she would tell me, but Adriana, how does the doctor pretend that if I am the one cooking at home, that I have a different menus? We don't have money at home to have different meals, and my family, they don't want to eat low in sodium. So the economy has an influence as well. Also, the availability and access to food. We know that more healthy foods are a little bit more expensive, and that's difficult, the access to food. And in terms of support networks, we know that the family as well as our friends, they play a role. They may be a protective or a risk factor. And I remember a lady who had a goal to lose weight and she was complaining, Doctor, but imagine we go to the supermarket and there I see my husband. He is getting Oreo cookies, chips, and this ice cream that I like. So we see how the people who are surrounding us have an influence on our eating decisions. And in terms of biological factors, we have the hunger and satiety that we know that are regulated by the hypothalamus, and any interaction or damage to this structure could alter our level of nutrition or appetite. And chronic diseases like obesity, diabetes, chronic pain could also affect our appetite, as well as taking some medications. And we know that the reduction in sleeping hours could also alter the hormones that control hunger. So if the eating behavior has multiple determinants, the interventions should also be multidimensional. And that's why before talking about intervention tools, it is important to understand one of the most frequent phenomenon in clinical practice, which is emotional eating. But before that, I would like to read some of your comments. And I see here that Kathy is saying that after church, we would go to eat gelato. Uh, or ice cream at the town square. When I behave well, I cannot read. Nicole, I don't know if you can help me with what is written. Yes, of course. Here, when I behave well, they would buy me a Happy Meal at McDonald's. That's a classic. In many homes, they use it as a reward. Thank you so much for your comments. And we can go to the next one. So we are going to learn to differentiate between what is physical versus emotional hunger. In terms of how fast it is showing up, the physical hunger is gradual and it develops several hours after the last meal, while the emotional hunger, it shows up all of a sudden, and it may show up even if the person already ate recently. In physical hunger, it is satisfied with a variety of foods and it is goes down once we reach satiety, while emotional hunger usually it goes through specific cravings and food high in fat and sugar. And also, we may feel the need to eat even though we are feeling full. In emotional hunger, in physical hunger, there are some physiological signs. For example, our stomach may be making some noises, while emotional hunger is related to uncomfortable emotions like anxiety, stress, sadness, and the physical hunger could be postponed or put on hold, while emotional hunger demands urgency and automatic or immediate intake. In terms of after eating, we can see that in physical hunger, and there is a sense of calmness, recovered energy, and physical well-being after eating, while in emotional hunger, it may be accompanied by other emotions that are uncomfortable, like shame, guilt, frustration. It is important to recognize that emotional eating is nothing bad or exclusive of people with a disorder in the eating behavior. Most likely, all of us here at certain time, we have celebrated with food. We have looked for comfort in a favorite food, a comfort food, or we have stopped eating when something is really concerning to us. If that sounds familiar to you, I invite you to type on the chat that you identified so we can see that this is a common human experience that is very generalized and it is not a problem per se. The problem is when eating becomes the only or main strategy to regulate my emotions. So that would be the problem per se. In fact, several scales have been developed to measure what is emotional eating. And as a supplementary document, I am going to share with you the Emotional Eater Questionnaire. It is a brief scale of 10 reactives that help us to measure the level of emotional eating of a person. And it includes reactions like, do you feel cravings for specific food when you're stressed out? Do you eat more? So you're going to have that available for you so you can use that tool in your clinical practices if you suspect that there is a patient who may be having this experience of emotional eating. We can go to the next, please. I love reading your comments and how you are identifying yourself. I really appreciate your engagement because that's what we want to have a good exchange of knowledge and learning. Here we're going to see the cycle of emotional eating. Usually the cycle starts with an unpleasant emotion, stress, anxiety, boredom, loneliness. Between the emotion and the behavior, usually there is a thought like it's only for today. I deserve this candy. If I eat this, I am going to feel better. And those thoughts facilitate the behavior. The person eats looking to feel comfort, not necessarily to uh, satisfy that physical hunger. And obviously, after eating, the person may feel a temporary relief or an immediate relief. And this is known as a negative reinforcement. This is very similar to when we get in the car and we drive without buckling up. You know that the car will start beeping. That's what makes us buckle up, so we stop the noise. The same thing happens with emotional eating. Since I feel uncomfortable, I have uncomfortable emotions, and I eat because I'm looking to feel better. However, it is a trap because that relief is only temporary. And once it goes away, that apparent relief, then new thoughts come up like I don't have control. I mess up my diet. I am never going to be able to change. And those thoughts are going to generate other uncomfortable emotions like frustration, guilt, and that emotional uncomfortable feelings then reinitiate the cycle, and we go back in the cycle. So beyond exploring what the patient actually ate, we need to explore the context of their behavior. And we may ask these questions, how we're going to identify these eating patterns in primary care. And that's why we have this guideline. First, we're going to start identifying what was happening before eating. What was the trigger? Was it a family argument? Was it work related stress, boredom? What emotion was present? So we are going to help the patient to identify how you were connected emotionally, and we are going to help them to name and define that emotion. We're also going to help them identify if it was a physical or an emotional hunger. We're going to explore the thoughts of our patient. What were they thinking at that moment? Do I deserve it? Is it only for today? Because many times those beliefs or those thoughts facilitate or keep this problematic eating behavior. And we're also going to explore what happened after eating. We're going to explore those consequences. How did you feel after eating, an hour after eating? So these questions are not trying to judge the emotional or the eating behavior of the patient, but to understand the function of that patient. If we don't have a lot of time, we could reduce this strategy to the three is emotions, event, emotion, and election. This means what was happening, what did you feel, and what decision you made and what happened after that. So we can go to the next one, please. As primary care professionals, our objective is not to do psychotherapy in a 15-minute intervention. However, we could incorporate brief interventions that help the patient to understand the function of their eating behavior and will allow them to develop ways to respond more appropriately to that uh, emotional discomfort. So we are going to develop these tools, and we have psychoeducation. We're going to help the patient to understand the relationship between their emotions and their eating. If necessary, we could educate them in that emotional eating cycle. And also, we are going to help them identify their emotions. And I am going to provide you with a tool that we're going to see very shortly. It is the wheels of emotions, and that strategy is going to help us to identify and differentiate emotions before and after eating. Also, we have the intervention of the conscious pause with the acronym PARA, stop in Spanish. And this strategy invite the patients to pause before eating to understand their internal experience in terms of what they are feeling emotionally and physically, to breathe slowly, to then take action or to elect from a conscious point of view. So this strategy is not looking to stop people from eating, but when we feel that urge to eat, usually there is a peak. And after that peak, we see a decrease in the emotion or the urgency or the discomfort. So, what this tool, conscious pause, is looking for to gain some time while that peak goes down. And then, when it is already going down, when the person is more calm, they can make better decisions. If they make the decision to eat or not to eat or what to eat. And we also have emotional regulation strategies because here the important thing is not to prevent the uncomfortable emotion, but to learn how to respond to that discomfort in a more adequate way or a more healthy way. And within those tools, we have diaphragmatic breathing, walking for a few minutes, writing down what you feel, or we could do a pleasant activity, and that would be uh, the contrary to that unpleasant emotion. So this is the wheel of emotions, and this is a version that I use in my private practice because this wheel was developed by Robert Plutchik in the 1980. He's from the United States. There are many versions and translations, and I like this chart, the way it is organized. However, I am going to be sharing with you this other version in Spanish, so you may use it with your patients in your clinical practices. And I am going to show you how to use it. If we take a look at the wheel in the center circle, there are the primary emotions. On the second circle, we have the secondary emotions. And the outer circle are the consequences of the emotion. Literature also calls them the sensation. I invite you to think about the last time that you ate and you were not so hungry. What emotion was present? How would you name that emotion? Let's think that that emotion was boredom, for example. If we take a look at the wheel, a bored is a secondary emotion to sadness in the second circle. So the wheel help us to name or identify the emotion, and that by itself help us to reduce the intensity of the emotion, but it also gives us a solution because it tells us that if we connect with an unpleasant emotion is because we are lacking the contrary. So if I am connecting with boredom and I know that the primary emotion is sadness, what I am lacking is that feeling of joyfulness. So if I am connecting with sadness, what can I do at that time that is going to help me to feel joyful? And that way we can self regulate and address that emotional experience of discomfort. Next, here we have a log of the eating behavior. This is an adaptation that I did using the more cognitive behavioral model, and it helps us to manage our emotions, our behaviors. And here we have uh, fields to document what was the situation, what was I feeling, what was I thinking, what was the behavior, if it was physical hunger or not, how did you feel afterwards, and the invitation to what other strategies you may try next time. Exercises like this help us to create more awareness of what I am experiencing. And many times it allows some space to make adjustments and to be more effective in our intervention. It is really important when these tools are not enough. For example, if all of a sudden we see on a patient some signs that may tell us that there may be a disorder in the eating behavior, it would be important to make a referral for a more specialized evaluation. And obviously, we would need a multidisciplinary approach. As a conclusion or key messages, we are going to review that not all eating decisions respond to hunger. Emotions influence eating. The family and friends, they could be a protective or a risk factor. The emotional regulation improves that adherence to the treatment or the nutritional plan. And the interdisciplinary management will produce the best outcomes. As a summary, when we understand the function of eating in the life of a patient, we stop questioning why is that patient not following the diet, not following instructions, and we start asking what does he or she need to be able to achieve uh, this goal. That will be all on my end. Thank you so much, Adriana. Thank you. And now we will continue. But first, I would like to see if you have any questions for Adriana. You may raise your hand or you may type your question on the chat. I think that we can answer one question before we go to the next educational session. I don't see any questions for the time being. So far, I don't see any questions. So everything is perfect, doctor. So now let's continue with the second session with Miss Keyla Ortiz. She is a registered nutritionist and dietitian. I'm sorry, I see a hand and it says, Miss Vida. I'm sorry, my name is Marta Garcia. Thank you so much. It is very interesting, your presentation. I think that you covered one of the aspects that is so useful. And it is a topic that is mandatory to think about it beyond the recommendations because it makes you think, for example, in the barriers that we need to consider when we're going to implement any changes with our patients. But I wanted to ask you a question or two in one. First, what are the most frequent challenges that you find in your practice when we want to implement strategies and recommendations? How frequent are these emotional factors? Is it in the common denominator of all the population? So I'm thinking that when we make recommendations, for example, from a medical point of view, including visiting the nutritionist as part of the team, it may be almost mandatory that also if there is a serious problem with the food, the psychologist must be included in the team, no doubt. And the second question, when we see all the presentation and people ask a lot, is it possible to help ourselves with what we are eating to improve our emotions? So that was the other perspective that maybe it will be covered at another time. But that was my second question. Thank you so much. This was really good, and I loved the approach.
Hello, thank you very much for the question, and I'm very happy that you've been able to enjoy what this series is all about up to now. As for the most frequent challenges, definitely it could be the emotional challenge, demotivation, or the problems with compliance, be it to the nutritional plan or the recommendations for the handling of chronic conditions. Tools like that registry for the behavior. So using that behavioral plan helps us to see what is going on, to see what is the internal experience, the emotions, the thoughts that are going on, the context, the family context, and the social context, and finally the behavior. So it's an invitation to create consciousness on what those internal experiences are and to see where the spaces are present to make some adjustments. So, as professionals, those spaces that you can identify, then you can make the referrals in order to promote an interdisciplinary approach. I want to ask for your forgiveness a little bit because I didn't hear your second question very well. I don't know, Nicole, if you can refresh it for me or the participant can ask that second question again. Marta, could you, I'm sorry, just the mic was off. It had to do with something very interesting that happens is that people, I mean, I like people to get information and get informed because it's the moment we're living in. But then there's a lot of information available. For example, when looking at the other aspect of mental health and nutrition, which is what helps us feel better. But what do I need to eat or what do you recommend? So that that also has a positive and therapeutic effect in my emotions. That's possibly a more open question or open-ended with more responses. But it's a frequent, is it a frequent question in your practice coming from the patients? Is it common for you? Yes, definitely. And I don't want to, you know, jump ahead because I know that my colleague now in her didactics is going to cover, and her intervention will cover that topic. If it remains unanswered, we will reopen the discussion forum, but I don't want to take over the information that my colleague is going to present to you. Thank you, Marta and Adriana. I think it's a good preview of what's coming with our nutritionist and dietitian. So let's start with her didactics. Kayla, go right ahead. We can see your screen. Thank you. Okay, good afternoon, everybody. I'm very happy to see you here. My name is, again, I'm Keyla Ortiz, and I will continue today with what our psychologist Adriana was covering within the objectives that I wanted to cover from my side to analyze the evidence over nutrition, mental health, and the feeding behavior and how these intertwine. Identify feeding behaviors that create risk or that show risk and to see the red flags, evaluate the nutritional factors, nutritional and social ones also, to intervene with brief strategies, brief practices, and no stigma. with no stigmas, and to be able to create referrals and coordinate when the patient requires it. Beyond what the patient eats, in this part, I wanted to prepare, and Adriana went over this a lot. So I would like to go forward to this diagram where she mentioned a lot of these points, but I would like to share this in a more practical maybe perspective and nutrition and what we face with our patients usually with why do I eat what I eat? So beyond what the patient eats, what factors are interfering in this behavior that the patient presents? Before we begin with nutrition and the foods we eat, I would like us to look at this as an introduction. Sleep, many times patients indicate us that I sleep 5 or 6 hours. I get up kind of in a bad mood. I can't catch sleep easily. But we have to go into this a little bit more because sometimes they're looking at screens or they have lots of caffeine, and sometimes they don't, or many times they do not make the connections with these. So we have to go into these areas because sometimes it's not just stress and worry, but also it can be from what they're drinking, eating, like caffeine and others that can interfere with sleep. The the corporeal image, your self-image also impacts this because it hits your self-esteem and it can be pushing the patient to say, I will eat this and not that, and I'll do it at this and this hour, and I'm going to this event, and I don't want to look in a certain way. But every time I get up in the morning and I look in the mirror, I don't like what I see, so I don't have breakfast. So there are many things that happen due to our body image, the experiences with the family. Like we heard before, we have the behavior from the time that they were children, that we start creating those habits, and the example of what we see. So the family experiences can also be present here in these aspects and these factors. Exercise, frequency and intensity defines if I eat this or that with carbohydrates or proteins, because now what's trending is high protein, but maybe at some point in time, the, the trend was low fat, then it was no salt. So this depends on the trend. So we have to recognize and be aware of what's going on, what's out there in the trends, because our patients will come with certain worries and comments and behaviors. And many times they relate to this, to what's trending. So, in the same way, we need to see how the exercise also impacts what they eat. Social networking, we are exposed to all of these influencers who can be sharing information, some of it valid, but many of them not really. There's no scientific evidence. They share them as their own experience and they want to recommend it to the public in general, but they generalize a lot. So we're in the social networks watching all of these influencers and content creators, and they're influencing a lot in what you buy and eat. So we need to touch on this. Previous diets also, maybe the Atkins or the keto one or the fasting. So many people have gone into lots of diets, and if we do not touch on them, we will not recognize what is the backstory of this patient. And the nutritionist, that's their expertise. So they need to kind of dig into this a little bit more in their private practice. But they can also include some questions in the questionnaires that patients fill out so that they can go into depth with it. So maybe they can lead the conversation in this direction. So I share these factors so that we feel and see that we go into what needs to be gone into with each patient. The access to food, I will be talking about this later, medication, because a lot of them can impact your appetite or also what you feel like eating. What's There's some medications that have to be ingested with food, others without food, and that impacts what the patients will eat. Also, the environment. Sometimes, many times they say, no, because what's on my way is this or that place. I don't know how to cook. Those are my eating places. So I would like to give them a diet plan with all of the different groups of foods, but I need to identify if this patient knows how to cook, does not show any interest in learning how to cook. They're telling me that the places where they go are this and that, because that's what they can afford. And they're the ones that are on their way when they're going home, and that's what they can do. So I need to respect this element of what the patient has in their environment. So let's look at those places, what we can combine. Can we maybe integrate this other food and combine it in that way? Because here we're trying to find the lacking nutrients. So trying to find alternatives within what their environment provides in their everyday life, okay? Hunger and satisfaction includes what they eat, because depending on these signals, and as a psychologist was sharing, she was trying to let us know to identify emotional or physical hunger. All of this impacts why we eat what we eat. And emotions go hand in hand with what we feel like eating, as the psychologist pointed out. I also want to share a little bit more and go a little bit beyond from what we eat and not create a stigma. A patient might have a normal weight, underweight, be overweight, and have obesity, and still present a significant restriction, lack of control, compulsive exercise, loss of control. Um, they can have compensatory behaviors, or they can also have feeding disorders. So even if they look obese, we cannot assume that they eat too much. In many cases, in fact, the patient actually that arrives with morbid obesity to my office many times is not eating the minimum for their metabolism. They're under the recommended daily ingestion. So even when we see people who look with morbid obesity is eating too much. So w- weight is not equal to eating behavior. So what about uh, food insecurity and food behavior? Let's look at the correlation. We're experimenting a lot of food insecurity, and it can get worse in Puerto Rico. So daily, we need, in our consultations, we need to give a space in our consultation to discuss and talk about this. Why? Because nowadays, with the situation that we have regarding water, that impacts what the person is going to buy, eat, and whether they have access to clean water. How are they going to cook the food? Also, we're in a country where we we don't grow what we eat, so we are also in a country where we have too much. Our our financial situation impacts everything, and our patient can say it's more it's more economical to get something in a fast food than to go to a restaurant where things get prepared immediately. All of these factors can be related with their feeding behavior. So the limited access to nutritional food can be impacted with all of this because there can be scarcity, something that they cannot pay. I had a patient, to give you context, who ate a lot of chips because her only meal that she could pay at home was her dinner. So throughout the whole day, she was just having chips, coffee, and a couple cookies. It wasn't that she wasn't hungry. It was That's what she could afford and what she had at hand regarding her finances. Of course, it had an impact in her physical and health conditions. Intense hunger and the worry about food can be impacted, eating too fast. So it can happen that I have now is when I can get fruit and vegetables, so I'm just going to eat them all before they get ruined, so that they don't so I don't lose them. So I'm going to eat them all. So even if I go through a few days or weeks that I cannot buy them, that can also be interfering with this because it's impacting our food security. And the lack of control has to do a lot with compensation, which the psychology talked about. So, implications for primary care before recommending. We refer to the nutritionist, but before thinking of a restrictive diet to lose weight or not to use this type of food without looking for alternatives, we must check within our consultations if in the last 6 or 12 months the patient has been worried because they might finish their food before they have money to buy more, and whether they bought some and they didn't last long enough. So maybe we're not asking the patient, do you have the money to buy this? But we're asking in a different way. We're taking them to respond and to answer so that we can interpret whether the patient has food insecurity. Okay. So we need to evaluate access, the compensatory behaviors, look at the referrals, and talk and refer to nutritionists and dietitians. Now, what can we do from nutrition side? We must get to know that we have bidirectional relationship. Our mental health impacts how we eat, but also how what we eat and how we eat can impact our mental health and our emotional state, our concentration, our energy, and our psychological well-being. So it is a bidirectional relationship. I should highlight that nutrition does not substitute psychotherapy or any other type of medical treatment, but it is an essential part of a holistic approach. When we were listening to the psychologist, we saw she spoke about anxiety and stress, and this can push to impulsive eating and snacking and reduce appetite to go for a long time without eating, amongst other things. Sadness can also relate to a lack of interest in eating, going out to buy food, getting choosing food conscientiously, or looking for food that makes them feel better. And many times, patients who are sad tell me that what they're usually looking for are sweet things, donuts, chocolate, ice cream. Some people feel happier with salty things, but mostly they go for sugar and the carbohydrates. Worrying too much over weight and being very self-conscious about the body image, so that takes us uh, to binging and then feeling guilty. Depression can also take us to a state where people don't really think and plan their food and their meals, so they have irregular meal hours or they skip meals. So when these behaviors become persistent, they can be related to problems with food behavior. Continuing with nutrition, before we go into the details of the nutrients and what's been evidenced, which can be good for us, we should point out that the brain needs energy and nutrients to work adequately. So, to have a diet that is not balanced and is not sufficient regarding macro and micronutrients. Macros, I mean proteins, or carbohydrates, and so on. But micros, vitamins and minerals, we need to find the balance to see what's been most evidenced. When it's not evidenced, what can it impact? In fatigue, low concentration, irritability, mood swings, more vulnerability to stress, and a loss of mental health and psychological well-being. So these nutrients, let's understand the macro, as I said, and vitamin B, zinc, and omega-3, which are the most studied, and that we've seen that they impact positively in this aspect, and vitamin B and vitamin D, these are key nutrients for neurotransmitters and cognitive function and to regulate that emotional state. So if we eat accordingly, we will have those benefits and improve our life quality. I wanted to prepare this image to explain in a easier way, manner, simpler way, how this evidence is going according to these nutrients nowadays. Generally speaking, even though not all interventions have the same backing or have a standard treatment, and many times we have to combine different recommendations or different patterns. In general, the most evidenced one is the Mediterranean pattern. This one also has a good result for cardiovascular health as well as for keeping a good weight, but also for mental health and the mental state and emotional state. So there's a lot of evidence in here, so it's promising, and it's it's quite balanced according to each patient. So they're the ones that have the most evidence. Then we have the omega-3, especially having EPA and DHA, because they complement a lot those who suffer from depression, and there's some heterogeneous evidence. Vitamin D is also being studied the for emotional health. You must always correct deficiencies, and the antidepressive effect is a bit uh, unknown. There's some observational studies. We have seen some changes and results, but we still need more evidence. Probiotics and microbiotics, the results are varied. There is no real recommendation that we can totally rely on, evidence-based, but it is they are showing signs of benefits. And the herbal supplements are being used all over the place with no recommendation. The evidence is insufficient, so they shouldn't be recommended routinely. And we must ask the patient the list of supplements that they're having, and sometimes the ones they're having interfere with their sleep quality, with symptoms, with medications. So sometimes the symptoms that we hear of are related to the use of medications and supplements. So we need to ask about that. What should we prioritize in our consultations? The individualized areas. It's the responsibility of the nutritionist and why the patient goes to a nutritionist. So we can create different documents, educational documents and forms where we can establish what is the pillar of the Mediterranean pattern. Fruits and vegetables that are the least processed as possible. So we're going to prioritize vegetables and fruits, legumes, grain, fish like salmon and sardines, nuts and seeds, olive oil, and other sources of protein that have no fat. So we're not looking for the super food, but the ideal food is what the patient can get, will consume, has access to, and can combine them. So that's what we're going to really be looking for the patient. Identify deficiencies is something we have to prioritize in our consultation, especially vitamin D, B12, folate, and iron. And it's very important because many times patients have a bad pattern or a food behavior that is not favorable for them. So they can show fatigue, um, mood swings, loss of hair. This can be related to nutritional elements, but we need to ask a little bit more, investigate a little bit more, working with the foods while we verify whether the patient needs a supplement. Regarding this data that can let us know a lot about the patient, and in consultations gives us like our little flags. Not all food behavior implies that you're eating too much. So we need to see that to omit consistently, to skip foods consistently. The one that gets impacted the most is the poor breakfast. They skip breakfast or they eat way below their needs. They start going on diets under the 1200 calories. There's a there's panic to certain groups of foods like carbohydrates, which are the ones that most people restrict uh, to rigid rules for eating, feeling guilty after eating, worrying about everything, weighing all the everything before they eat them, and to be weighing themselves compulsively. And to finish up, these 5 questions, we can add them in a questionnaire before our consultation, before they go into our consult first. Has your appetite changed recently? Are you skipping foods or going for long periods without eating? Have you ever felt the loss of control when you're eating? What happens with your food or your diet when you are stressed, sad, or anxious? And how much of the day do you feel that you're employing and thinking about food, weight, or exercise? So those questions would go should be in your questionnaire. Well, I suggest they're in your questionnaire. They can help us understand the patient a bit more and see what we can adjust in the recommendations that we present to them. I wanted to add this for a good communication that will help in the results. So instead of asking them when they arrive, why didn't you comply with it? Is it's more to go into what was more difficult for you to do. What happened that you were unable to implement the plan? What factors are being difficult for you in this change? Before saying, hey, you should control what you eat, to say, what happens before you feel that loss of control? What's going on? What's going on when the patient runs to certain foods? Also, to avoid saying, just eat less. I mean, it's quite easy to say like that, but patients then face this in social networks. So instead of emphasizing that, so simple, but it's not, because patients have lots of feelings and thoughts. They've got medications, they've got a certain idiosyncrasy and things that might be interfering. So it's better to talk about before modifying quantities, let's talk about timelines, what foods you have access to, how we can combine them. What do you think if we prepare them instead of like that, like this, and explain why? Because the patient needs to know the context of why I should not eat potatoes in this way, but then I'm being told to eat them in this other way. What does it have or doesn't have? What can it produce? When they understand reasons and consequences, the patient can see we've seen better results of how the patient begins to modify habits. Why don't you buy healthy food? Well, instead of asking like this or assuming that, they didn't buy all the food because they didn't feel like it, like fresh salmon, berries, and etc. Well, what foods are accessible to you. So we can see, according to what has been recommended, what are the foods that they can actually buy. And instead of finding a way to start asking what the person weighs, to respect that they might not to weigh themselves and ask them if it's something that they want to do, but it's not something we need to focus on. We should focus more on asking about what changes they noted, they saw in their food. Man, I'm now including vegetables. I didn't do that before. Or now at breakfast, I'm integrating protein because before I just had bread and butter, and now I'm having a boiled egg. All of those things, all of those changes, we need to ask about them before talking about the weight to emphasize how they feel, how their energy is, if they're sleeping better, and the overall well being. And finally, practical strategies for your consult. So these are questions that I would like you to have and that they're free of judgment in the consult. Also, evaluate with intention, open ended questions. That way they can give us what they feel. When it's indicated to use practices that we can apply, evaluate the clinical impact beyond weight. I mean, um, what you're eating, energy, sleep, to look at those red flags, because when we have open-ended questions, we can pick up on red flags that the patient might express in their experiences, and we can find them and have an intervention with small goals and that they're realistic and that can be established and that we can achieve together, but something that the patient can really implement. The recommendations for nutrition that are general, while why the patient goes to nutrition, talk about physical activity with general recommendations, while the patient gets up to speed in their exercise, and then handles stress and anxiety. And the focus is really to promote a more balanced diet, do follow up and reinforcement, and refer when it's necessary to nutrition, psychologist, psychiatrist, or any of the interdisciplinary team. So these are my references. Thank you very much. And I am here for any question or doubt that you might have. Thank you, Kayla. Here would like to invite all of you to raise your hand for any question that you might have for Kayla. You can use the chat. So let's give you a couple minutes for that. And I would like to take advantage of the time. So I will put the post test here on screen. Now you should be able to see the post test on your screen and a link in the chat. I have here a couple questions, but I am not sure. Mariluz Marrero Rivera had asked what genetic or organic factors can be related to the physical or emotional inclination towards certain foods. I don't know if Mariluz would like to open her mic. And how can we reduce cholesterol considering integral health? I don't know if maybe that second question could be directed to the nutritionist. How to reduce the level of cholesterol considering integral health. Okay, cholesterol is something that can be increasing because of different factors. Sometimes it's genetic, but physical inactivity influences in the cholesterol increase. Many times people are sitting and working, then they get in the car, get home, maybe they walk standing, doing something at home, but then they sit to watch TV. That pattern of inactivity provokes a raise in cholesterol. Nowadays, the insufficiency or deficiency of fiber takes is able to take cholesterol out in the feces. People are not having integral food. They're not using carbohydrates with integral things. They're not eating grains, fruits, or vegetables. So at least between two, try to take 4 portions a day. We don't between 25 or 28 grams of fibers a day. So we need to reinforce and try to get to between 25 and 28 grams of dietary fiber per day. Okay. I was activity, physical activity, water, dietary fiber, and as far as food goes, what's evidence is saturated fat increases cholesterol, which means the full whole milk, cheese that are not low in fat, whole yogurt, whole milk yogurt, meats have different levels of cholesterol. For example, a churrasco is T-bone steak is high in cholesterol. Ground meat that it's not lean has a lot of cholesterol. One so our animal protein gives us a lot of cholesterol. We don't have to take it out, but we can look at better alternatives in order to reduce cholesterol consumption. And I mean saturated fat that increases cholesterol. Cakes, donuts, ice cream, cookies, since they have so much saturated fat, increase the cholesterol. So the recommendation in all of these, including butter and amongst others, because there are quite a few, if we substitute these foods and we bring them down and we start integrating healthy oils like sardines, salmon, seeds, and nuts, and we bring up the healthy fats and bring down the saturated fats, we see a change in the cholesterol. Dr. Mariluz, thank you for answering the question, but also I wrote a comment that I have seen a tendency in people buying cans of pork fat. And I went to a doctor and he said that he was not recommending um, avocado oil. So I continue to use olive oil, but I've seen people taking, like in the 50s, pork fat. I don't know what's going on with that. If you have any opinion about it.
No, well, that is something that is being studied a lot, and there are studies. But the thing is that new things comes up, and influencers. Well, avocado oil certainly had was very popular, and with all of this that happened with certain products that were not complying with what they say that had avocado oil, and actually it didn't have that amount. It was mixed inflammatory oils, so we cannot trust in everything that the product said because there are not enough agencies to confirm that the products can comply with what they claim. That's why we need to recommend to minimize the intake of processed food, because there is no way that they are going to change. Well, not at all, but they are not going to change, for example, an apple, a banana. Maybe they have something added in terms to keep the color or something else, but the context The lard has a heating point higher than other oils that could oxidize and could be harmful. So it is not that it is better because of that reason. Well, we are not recommending to fry food, so the food should not get to that point in terms of cooking. But yes, definitely what we should prioritize is the intake of olive oil that holds very well what we cook usually. And lard is completely saturated fat, the same as coconut oil. And there's a lot of evidence showing that it both increase cholesterol. And one of the factors or the causes of death nowadays, the first cause is cardiovascular diseases. So we cannot continue consuming food that increase cholesterol because that's one of the highest or the main risks. I saw here. Oh, thank you very much. Thank you. Yes, I don't know if that was the other comment. On my end, I think there was another question for the psychologist. I think. Yes, I think that it was also from the same colleague, right? What factors? Let me see. From Marius. Adriana, if you could answer this question, what genetic or organic factors could be related to a physical or emotional inclination by certain food? Yes, basically, as part of that is a behavioral approach that I have a competition on that. I could tell you that when we talk about emotional hunger, that is also known as hedonic hunger, the brain reward system is activated and it makes the person to feel more desire to eat food high in fat and high in sugar. Uh, they are known as a hyperpalatable food. And when we have that emotional discomfort, we have the habit of relieving that discomfort with this kind of food. And our brain every time is going to be asking more and more of that food and in higher amount to get that immediate relief. Thank you so much, Dr. Adriana. And now we are going to continue with our colleague, Franceli Sanchez. She's going to be talking about the clinical case. Please go ahead, Francelis. Now, thank you very much. I was on mute. Well, today we have a female, a 49-year-old patient. She's 5'5", initial weight 230, and current weight 210. She lost 19.2 pounds, around 8.3%. The reason for the consult is losing weight and to improve body composition. The patient manifested a special interest in continuing losing weight and body fat and to increase muscle mass. In relevant background, she has hypothyroidism, coronary acute syndrome, asthma, gastrointestinal conditions, anxiety, and sleep alteration. In her eating history and the behavior related to weight, since childhood, she referred a very small variety of food, repetitive eating the same food, and she felt obliged to eat. Now in adulthood, she had gone through several diets, including uh, reports of 800 to 1200 calories per day. She has expressed that she feels frustrated and confused because she's receiving multiple recommendations. Currently, she has a significant concern regarding her weight and her muscle mass. She weighs herself almost daily. She doesn't have a lot of appetite. She omits her food frequently, her meals. She has documented a decrease in her intake in less than 50% of the estimated required energy requirements. She keeps a limited food variety, even though she's have a low intake. Uh, she continues saying that she would like to lose weight. She exercises and she would like to receive psychological evaluation. A typical day, she wakes up at 4:30. She has her coffee at 6:30. She walks for 2 to 3 miles. At noon, she has a snack. Occasionally, it may be a yogurt and almonds. During the day, she takes one low-calorie LaCroix. At the gym, her session could be approximately 3 hours at 5:20. She takes her main meal. It could be a chicken wrap, a salad, chipotle, sour cream. And as option two, she has a rice and green pigeon peas and chicken. She goes to bed at 9. She takes water and she wakes up approximately 6 times during the night to go to the bathroom. And she is visiting her urologist. In previous evaluations, we have documented also that she's sleeping approximately 5 to 6 hours a night. In terms of physical activity, that is an important part of her routine. She walks 2 to 3 miles. She lifts weights and uses her machines, prolonged training, gym sessions of around 3 hours. And she has a history of exercise approximately 5 times a week. In certain times, she has reported physical activity for 7 times a week. In other follow-up appointments, she documented 3 hours of physical activity a day, 5 days a week, but she was reporting that she was feeling weak and tired. The nutrition focused physical findings, low energy, she's losing hair. She refers that she is taking Nutrafol and she's not feeling any improvement, frequent uh, weakness and she feels tired, poor appetite, she's not sleeping well, and she wakes up frequently to go to the bathroom during the night. And these findings would require an evaluation. In terms of her medications, she's taking Brilinta 60 milligrams twice a day, atorvastatin 20 milligrams once a day, carvedilol 3.125 milligrams twice a day, Nurtec 75 milligrams when she has a migraine, omeprazole 40 milligrams a day, and Thrology for pulmonary issues. In terms of supplements, Mega Food Multivitamin, COQ10, oregano oil, vitamin D, 10 units a day. She takes it approximately once a month. Vitamin B12 and creatine, 2 scoops a day. This lab work, she has a vitamin D in 33.5, an A1C in 5.4, fasting blood sugar on 105, total cholesterol 113, 111. So basically, it is an open question. How would you manage this patient? What recommendations would you give her regarding considering your expertise and your education? So we have the psychological context, so maybe you would like to talk about that. You can raise your hand, use a microphone to give your recommendation, or you can type your recommendations on the chat. We have Juan Roman. Would you like to open your microphone to give your recommendations? Yes, hello, good afternoon. Hi. Well, I was reading this clinical case, and it's a young female patient that definitely we would need to verify her lab work to have a screening regarding her hypothyroidism condition. We should check the adherence to her medication to control her thyroid. We know that hypothyroidism could lead to obesity in our patients. And I also see that she has an exercise routine that is excellent. We would need to see the style of training that she's doing. We know that resistance training is going to promote uh, losing weight, burning fat, and it increases the glucose receptors in muscle receptors look for. So on that hand, she keeps her glucose levels in blood very stable. But we see that she has polyuria. She's waking up frequently during the night to go to the bathroom. And even though her A1C apparently is 5.4, we will need to check in more detail to rule out any condition like type 2 diabetes, for example. So we should refer also to the endocrinologist so she may receive an evaluation and she may have a follow-up with the endocrinologist referring her condition. So I think that's what I have to say, and thank you. Thank you very much, Juan Roman. Cathiola, you may enable your microphone to provide your recommendation if you want to do so. Thank you. Yes, I agree with the doctor, but in addition and reviewing the case, the patient is having a caloric intake uh, lower than 1,000. So we're talking about 800 to 1,000 calories or 1,200 calories. She's over exercising, and in addition to that, she's having a hydric intake of more than a gallon and very close also to the hours before going to bed, and that may cause that she is waking up frequently during the night to go to the bathroom and she is interrupting her sleep during the night. And that creates like a cycle that exacerbates because then she is adding sleep interruption. So this is another contributing factor, uh, a contributing factor to her condition. Well, I would reevaluate since she has a current weight of, let me see, currently She lost 8% of her body weight, and so we could make a readjustment with her current weight to calculate having a weight loss of 8% in the next 3 months, ensuring that she has the necessary caloric intake so her basal metabolism could go according to that. And I would measure the levels of ferritin because she's only eating two kind of foods. So then she could have more variety and to incorporate fruits and vegetables, ensuring that the amount of macro and micro foods are according to that. So that would be my recommendation. Thank you very much. So now we are going to continue with Dr. Leticia Hernandez. Doctor, I don't know if you would like to provide any recommendation. Hello, I have a question. I was not able to listen to the age of the patient. If you could please confirm. 49 years old. 49 years old. Okay. Well, there are several things. First, this patient it could be perimenopausal. She may be having uh, uh, genital urinary syndrome, contributing to the excessive intake of water and affecting her sleep. And that's going to affect her capacity to lose weight because she is going to have alterations in the levels of ghrelin and lectin secondary to poor sleep. In terms of hypothyroidism is not really associated with obesity. The weight gain associated when it is not controlled, it is from 5 to 10 pounds approximately, and mostly because of fluid accumulation. But maybe we need to adjust the dosage to this patient since she lost weight. Maybe her requirements are lower now. Now, seeing the whole case, this person has all the red flags of a serious eating disorder because she has an excess of exercise, an intake much lower than the basic requirements. And even though she's still not prepared to receive the psychological help that she needs, we need to remember that the obesity has very important psychological components and it could be related to eating disorders. So this patient could be taken step by step so she could understand the need to include psychological assistance as part of this process of losing weight to do it in a more healthy way. Definitely, as the doctor mentioned, she must have a deficiency of micronutrients, and this could affect her total functioning in the present and in the future. She could be at risk of other conditions like osteoporosis. And in fact, her fasting blood sugar is elevated, so she may be pre-diabetic. We would need to verify that value of fasting blood sugar again, uh, and also postprandial value. We need to check. And she needs a multidisciplinary team to approach her. Ideally, her primary care physician, her endocrinologist, and nutritionist, and also uh, mental health professional should be included because I am seeing all the red flags that there is an eating disorder that we need to work on. Perfect. Thank you very much, doctor. We see that we are driving, so and continue listening to us, but please pay attention to the road, please. And thank you for being present here. That's our recommendation. And it's an excellent recommendation from you. I think that now we can continue with our nutritionist or our doctor, Dr. Ovid. Any of you, please. Yes. Well, very briefly, this patient Definitely, I agree totally with Dr. Hernandez. She's showing all the red flags for an eating disorder. So this patient is eating too few calories versus what she's spending in exercise. And this patient also, we have seen in the visits, to give you some context, she has been with me for approximately a year. And this patient in our consult, she's always denying to integrate psychologists to her multidisciplinary team. Uh, I don't tell her at every visit, but the times that I have approached her, she's totally rejecting it. She indicates that at a certain time she had a psychologist and it was worse. She has verbalized that she felt worse when she went to the psychologist, and that's why she's not going back to see any psychologist. So convincing her, it's really difficult. I see her very frequently in terms of continuation of her treatment. She has a primary care physician. I have referred her to the endocrinologist, and she's in that process right now. But to continue increasing her multidisciplinary team, it has been an uphill battle. The same what I have been able to work with her, not highlighting her weight. I don't want to weight her every time that she comes in, but every time that she comes, we need to weight her. At a certain time, I wanted this patient to eat because she was not eating. So that intake that you see there is a little bit more than what she usually reports at the consult, but it is lower than her minimal requirements, her basal metabolism. And I had to see her in just a week because she made a commitment that she was not going to weigh herself at home, that she was going to trust. I am giving you this context very briefly. She was going to trust that eating a little bit more, as I suggested to her, and it was not a lot, but it was a little bit more than what she was eating at the time. That eating a little bit more, she made a commitment to come back to weigh herself in a week. So I agreed because my goal was for her to eat more because she was eating too little. She ate more. She came to the consult. She lost weight. She increased her muscle mass and she felt more energetic and she felt very motivated to then start eating a little bit more. But then she took a step back, and that was on Christmas season. She had several changes in her routine and she gained a few pounds, not a lot, but for her. And within her condition, her mental health condition, increasing 3 pounds was too much. So in children, uh, so she went back. And it has been a very interesting case, and it has been difficult to integrate her pillar because the endocrinologist is very necessary. We know that it is necessary, but so in terms of incorporating more foods in her intake, she has been able to integrate some of them, but we still have a long way to go. And additionally, this patient, to convince her to lower her physical activity was very difficult. She's in that process right now. She has lowered a little bit her physical activity to balance what she's eating to what how much she's uh, uh, exercising. So she's also the fasting has been difficult with her because she's uh, does it and then stops and does it and then stops. So thanks to this, she was able to reduce her weight because when she was eating too little, she was not able to achieve that weight loss. Now that she's eating more, we have been seeing that she's losing more weight. We have worked a lot with her, but as a summary, another important thing that we have been working with her was to be able to review, blood work, folate, thyroid, iron, the CMP, vitamin D, and other studies that other doctors recommended, like her primary care physician and her endocrinologist, uh, they recommended other blood work. In terms of hydration, she drinks more than a gallon, even though it is she's still working with her urologist, but sometimes she's very thirsty, and she was eating very a lot of processed food high in sodium, and that's why she was feeling more thirst. So we are working on that, and we are waiting for the results from her urologist. Okay, and now since we are running out of time, we are going to continue with you very quickly, Kayla, so you can give us your feedback. And I know that we already went over a few minutes, but those who would like to stay, you're welcome. Basically, I like this case because we see how the eating behavior goes beyond just asking the patient is eating or not. If we use the analogy of the iceberg in this case, I think we could understand it much better. And that behavior of losing weight, omitting some meals, a low intake, excessive exercise, we can see that, but we need to ask what factors are influencing this behavior. What are those social family factors, like, for example, in her childhood, having an exposure to a low variety of food? Psychological factors, she is connecting with emotions like frustration, confusion. In terms of her thoughts, she has an automatic thought that I need to continue losing weight. And she is reinforcing that problematic behavior with that. And the biological factors, as some of the physicians mentioned, the poor appetite, low energy, interrupted sleep, chronic diseases, and the use of some medications that could be altering her appetite. Well, I think that the most important is to highlight that discrepancy in terms of what the patient is looking for, which is losing weight, versus what is doing. So this is a great case to apply that logbook of the behavior, where the patient is going to be able to create an awareness of what are her internal experiences in terms of eating. And many times when the people have a broader perspective of what is going on with them, and they are more willing to open to the idea of seeing what other resources are available, because that logbook is a way to show how the way that she's managing right now is not being actually useful for her, and that may motivate her and invite her to consider other alternatives. Obviously, we don't need to highlight that she has a problem, but that we have tried this so far and it has not been enough. We are not approaching what you would like to achieve. So, what else do we have available? What else would you be willing to try? And we're going to do it with her own information, and that's the wonderful thing about this logbook. And obviously, we are seeing some signs that let us know that this patient could be having some criteria for a disorder in her eating behavior. And that's why a specialized evaluation is so important. And this patient could benefit from a multidisciplinary approach. Thank you so much for all the recommendations. Thank you for your participation. So that will be all for today. We went over a few minutes, but it was so important to finish that discussion. And we appreciate all of you for joining us, for your engagement. Juan, Dr. Hernandez, Marta, Kathy, Olga, Estrella, thank you all. And with nothing else uh, but to announce our digital health events that we are having. Our next listening session will be in Ponce and also in Atillo. August 25th in Parador El Buen Café. The register is still open. And we also have the digital library where we are going to have all the resources that Adriana mentioned and Keyla Ortiz mentioned. Also, today's presentation will be available. So if you would like to review it or to use any of the applicable practices, you could do it. It is available for you. And the last session will be on September 6th from 3 to 4:30. And again, we're going to have Miss Keyla Ortiz, and it is going to be nutritional intervention in primary care, a practical approach. So if you have any case that you would like to discuss, you can share it with us through the form that we will be sending you. We appreciate your participation. And the final greeting to the colleagues that offer this excellent session. Thank you so much, and until the next session, have a nice afternoon.